So we are a small group, so let's do it a little in a dynamic way instead of just me talking. Let's do it a little in a dynamic way. Okay, I'm Dr. Abbasi. I'm a neurosurgeon. I'm trained in Germany. I'm trained in Stanford, in Dartmouth, in Texas, and I have been doing lots of minimal invasive cases, and that's all before I started even working with Amindia. So the OLIF or CALIF, however you want to call it, I'm going to use the word OLIF, OLLIF, came natural to me, and I understood what it really does, what it really changes. So just dive into that. Now, who would change the oil in his car like this? Nobody. But in reality, this is how we do spine surgery today. And that has to change. This is how we should change oil in your car. And I'm going to talk to you, and for people who understand that, they know what that really means. And I think since you're all specialists or in the profession, then I can explain it to you. Now let's talk a little about the different kind of surgeries that these days are done for spine. Okay, now we know all about the TLIF, which was propagated in 1983 in Germany actually. It took about 10-15 years to become a standard of care, but it's still a standard of care. It's a procedure that was invented in 1983. In 2016 is a standard of care. And in other industries and so on, nothing really lasts that long. And then, yes, we came up with other things. PLIF came actually about posterior lumbar interbody fusion, where you go straight down, you do the medial facetectomy. That came about 15 years or 20 years before that. And that was standard of care until we find out that TLIF is better, taking the whole facet off, going through the foramen. It reduces this neurological deficit. But then we noticed TLIF, when I started learning that, we would do one level TLIF. It took us about 7 to 8 hours, and that was a normal thing. And I still have patients that when they go get their TLIF, and they come and say, it was a 6-7 hour surgery. As a matter of fact, you guys know Chris. Chris got a spine surgery, a 2-level fusion. Chris, the person who works with me with Amindia, he got an OLLIF, and this is a procedure we discovered or invented because we weren't quite happy with TLIF. And where you go practically intra or actually retroperitoneal or infraperitoneal, depending on your exposure surgery, you might be intraperitoneal, retroperitoneal, or lateral to peritoneum. And then you have, most of people do instrument from the back as well, so it's a 360, meaning you operate from the front, put a cage in, and then you go from the back. Chris got this surgery, he was 12 hours in the surgery for 2 levels. Just keep that in mind. Now let's move on. Then we came up with the direct lateral, extreme lateral, direct lateral, depending on the company, where you position the patient on the side, you literally break the table so you have an exposure from the side, you prep through the muscle, you go put the cage in, and then you turn the patient, and yes, you always have to turn the patient to do the posterior instrumentation because the results, and I can give you horror stories, are horrible. If you don't do that, people start doing this spinal clamps from the lateral, people start doing this and that. I can show you pictures, true horror stories, how those cages back up, and and we just take my word for that, as somebody who has been doing this for tens of years. If you do it, it's a good procedure. You always have to back it up with a posterior instrumentation, preferably bilaterally. So this is, and here we are still talking about the full 1 level. Maybe in a good hand, 1 hour surgery, half an hour to 45 minutes, maybe an hour, depending on your support, just to turn the position. And somewhere between an hour or 3, depending on, again, your experience. So we are talking about 4 to 5 hour surgery as well. Then there is a OLIF, Medtronic, which is practically modification of the OLIF, where you go not infraperitoneal, you go lateral to the peritoneum, but you go just, depending on the level, you modify it to get a lateral approach. But patient again is literally supine. And you do the surgery, you turn the patient and then do the posterior part. Now, we are not going to talk about all of this. We are going to talk about OLIF. Let's just dive into that. And I'm going to explain that a little more. And these are the marking on one of my patients. If I was going to do a PLIF, I would do a midline and go straight down. If I was going to do the TLIF, I was still going to open it this way, but then go a little more lateral to get an oblique angle through the facet or foramen, hence transforaminal lumbar interbody fusion. This is a procedure that we neurosurgeons do for if you want to approach a ganglion for something like schwannoma and so on. It's very specific. But then here you see the approach for the direct lateral right here, and 15, somewhere between 15 and 10 is usually, depending on the patient, and these are centimeters, is your OLIF approach. Now, this is a open surgery of my patient, and this is a minimal invasive surgery. And let's just talk a little about the muscular structure in the body. I think this is information you guys know, but it would be valuable to rest of you. If you look at the bone, you see lots of processes, like spinal process, transverse process. They are not there for good look. They are there for muscle to attach to them, to have a fulcrum effect and have a good motion in the spine. And there are thousands of them. And those muscles, they are not just from one segment, they are multi-segmental. They meaning that, if you do surgery on L4-5, you're detaching the muscle that they go usually 2 or 3 levels above and below in that immediate step, and then much higher and much higher. So practically you're detaching all those muscles. Now, be my guest. Guess why if you do a surgery, patients start moving, all of a sudden they have this horrible spasm in the back that debilitate them for weeks and months, and then their spine is destabilized, and then we give them muscle relaxant, we give them flexural, we give them lots of baclofen and so on, visceral, to counteract that. Well, you detach one end of the muscle, and the muscle is trying to work, but they have nothing attached to, and then you have the result of this long recovery. Then we have these papers that spinal surgery doesn't work. Spinal surgery doesn't work because this is how we do the spinal surgery. We need to change that. Now, let's go back now to anatomy. Now, again, how many of those muscles do you think in a regular surgery do we connect back? Like, if you do an arm surgery or elbow surgery, you attach every single muscle again, otherwise you lose the function. How many of these muscles do you think we reattach when we do spine surgery? 0, right? Or have you ever seen a spine surgeon going and reattaching those muscles? Now, and let's talk about the OLIF now, okay? I think the point here is that I cannot use that on that, but it doesn't show up there. But the idea is to find a place that you can bypass the neurovascular structure and get a safe approach to the spine. And that approach is, we call it Cambine triangle. It's practically size of my nail and my index finger regularly. And the borders are facet, the pedicle, and the nerve root. And to find that, actually, that is a big deal to how to find that. And it took us, many decades of research to just find that place. But like anything else, once you find it, you can develop method to utilize it. And I'm going to come back to that, and we are going to show the positioning and so on. There is some math to that, but this is a doable math. This is not a quantum mechanic math, okay? But you have to know what you're doing. Again, I will come back to that, and I will show you the video, which shows that better than I can just explain that. And then we use a set of smart tools to utilize through this approach to get the bad disc out, to put a spacer in that prevent the two vertebral body to collapse, and then we stabilize it as is the standard of care with any of those other procedures. So I have a video there. Instead of showing you in function of each of these, I'm just going to shorten it by going to that video. If I find it, I'm not sure.
Is it the amended video?
Yes, amended video, yeah.
Okay. You don't have it, I have it on my other laptop.
Yeah, I have it somewhere. I think that might be it actually. I'm not sure. Yeah, I think that's it. So, ganglion, nerve root, Cambion triangle, and obviously the facet, the positioning of the patient. I bring my C-arm above. We will show it to you. However you do it, you need a good bilateral fluoroscopic imaging. You need to mark the midline. You need to know if there's a rotation. You need to know that. Then obviously the lateral view, you need to again have a good lateral view, and on the disc that you're going to approach, you have to be able to see it very clearly. Then practically, it's a simple matter of that is you want to go 45-degree. For that, you have to find out the top and the lateral side, and halfway between where you can triangulate the Cambion triangle. And we use a method of neuromonitoring with that, meaning you put electricity on this. There's a pad on the patient, and there's SSCP and so on, that you can see if you are hitting a nerve root with the EMG signal. If you hit it, you have to just position it where there is a free approach to the disc base, and we talk about how is the best to find that approach. Now, once you are on top of your interested disc, you put a K-wire in, you dilate, and that's a very important thing. When you dilate, I show you pictures that shows it opens the foramen. It doesn't push more the nerve root. It literally opens up the space. Then you put a cannula in, and you created now from the skin to the disc a safe path. And you can use these smart tools that I just showed you before to take the disc out. And there are lots of information that you need to just consider when you are doing this. At first, I was I think more aggressive than I needed to be. What you need to do is provide a path from one bone to another, and by providing that path, osteoblasts, they just grow through and provide you with the stability, with the final stability, which is the fusion. You feel after you use these different tools to provide your cavity and refresh the surface of the bone, you fill that space with tricalcium phosphate, which is a ceramic, but you can use any kind of biologic. It's I use that because if I use a bone marrow which has stem cell, which I get from my Jamshidish when I'm doing my pedicle screws, and combination of the bone marrow and the tricalcium phosphate has worked well for me. And then you put that cage. We talk about the cage extra because it has a conical shape and it produces its own path. And I have been, before I did that, my usual cage size were between 7 and 10. Now my usual cage size are between 10 and 15. And as you know, there are some information out there that if you have an interpedicular space from 14, your absolute goal for indirect decompression, that foramen has no pressure anymore if you have 14 now. We start usually on, because distance between the pedicle is never zero, obviously. Even if the disc is completely gone, it is somewhere between 7 and 8. And by us adding a cage that increase that about somewhere between 3 and 7 millimeter, actually, we are providing an indirect decompression. Now, we talk about the positioning in the room, we talk about the coverage in the room, and this is a very important part. When we started that 4 years ago, this took 45 minutes. Now it takes us 5 minutes to do that. You have to have a team, you have to have a support structure. And do you know who is my best support structure? my media distributorship because, or Devin, who knows exactly what I need, and if there's a new nurse and so on, they don't have to guess. He said, okay, Abbasi likes it this way, and so on and so forth. And if you support them, they, tell them, listen to them. He knows what he's doing. Then they sort of set it up for you the way you want it. And then we can, on the cadaver, go over the measurements. And we will talk again in the room, hand-on, about the tools. And then the rest of it is, let me see if this is a video as well. No, that was
Dr. Abbasi, the discectomy that you do you find that the tools are sufficient enough to
more than
get
enough.
that kind of that back
Yeah,
side?
and I think we will get to that when we are toward the end of the presentation. I don't think that. I have the study, I have the data. I know it is enough because I follow them up 3 months, 6 months, 9 months, year with CAT scan, and I see fusion happening. And my fusion happening, our preliminary results are not out there. This is our landmark study that we are going to talk at the end of the talk. It is comparable or higher than standard surgery. So we'll talk about that. Here's, obviously, this is a multi-level fusion. And if you're going to start that, you're gonna start it on easy case like anything else. You don't go fly the fighter jet. You start with a two-seaters with the thing and so on, and you move on and so on. But you can do. I have done scoliosis cases, and I put my cards somewhere out there. Just take my card. If you have a question, let me know. Go to my blog. There are lots of information about how you can modify this and get actually much more mileage of this procedure. It's hard to do a scoliosis where the two vertebral bodies are totally malaligned, but we will talk about that a little more later on. So these are the studies we produced, okay? For busy surgeon, it is lots of work, and we surgeons are extremely busy, but I feel an obligation to go out and talk about this. And we did this paper first for a reason, because I'm convinced that this should be standard of care, independent from MND. I think it's just a fantastic result for my patient. This should be standard of care. And how can we make something standard of care in the United States? We have to show it is equivalent or cheaper and have equivalent or better results. For that reason, we did this study first that compares what is really the cost of surgery in the United States. Now, what do you guys think? What's the 1 minute OR time average in the United States?
$87.
You are very good, actually. Yeah, but it's somewhere between 60, depending on the hospital, between 60 and $100. 1 minute. So, a 7-hour fusion. I mean,
Adds up.
just think about that. 7-hour fusion for 1-level surgery. In best hand, in the fastest surgeon I have ever seen in my life. A 1-level fusion is 1 hour and 1.5 hours. And that is, I'm talking about, the Picasso of surgeons, okay? Let's say 2 hours, 120 minutes. And let's say, just to round things up, $100 an hour. So that makes it $12,000 just the OR time, Now, just to throw it out, some of you know that. What do you think, what is my record time on this? It's not about the speed, but the speed comes when you get efficient. My record time is 28 minutes.
No.
Yes, this is a recorded time, skin to skin but this is not a race. Surgery is not a race. You are not doing it to be fast or faster than anybody else. But once you become efficient, it is just, things just flow, and the result of that, so I am 3 times faster than the Picasso of the spine fusion surgeon, not because I have super skills, but because I have put a system together, a team together that can support me with a good procedure to produce the good result. But again, all of that is meaningless if you don't have the results.
I don't
Here
want to
are
take
the
anything away
results.
from Dr. Abbasi, but
Yeah.
when he says 28 minutes, he's not alone. I know 3 other surgeons that work, and they do this in the half-hour to 45-minute time range.
And that is important
It's
information.
he's not an isolated event
No,
here.
and this is important information, you know. You always can have Stephen Hawking or Albert Einstein, but if you produce something, a map that random Joe can do, then you have a standard of care. You cannot build a standard of care on spectacular surgeons. You need to have something that you can apply to more and more people, and that is I think that's something I'm going to use. That I'm not alone in that, because I think that's and no, that doesn't take anything away from me. But I want this to be on the process, because this does change our patient care. But all of that is meaningless if you don't have results. And let's talk about the results a little. Now, when I started doing that and I saw the potential, my eyes were on the big prize, meaning that, how can we really make it that everybody get this service? And now I know it's hard to sometimes to conceive that, but one of my teacher, and they words has been really deep in me, says, do the right thing for the patient, everything else comes by its own. And this is the right thing for our patient. Now, what did we do in this study? First of all, I started gathering all my TLIF cases, and once I started doing OLIF, I still was doing TLIF and OLIF. I was choosing the patient, but I didn't use those patients for my comparison study, because I didn't want the selection bias be part of my calculation. So I did probably 50 to 60 TLIF patients, and then every single OLIF patient afterward, until I had 60 cases. This is a study we published about a year ago. Now we are going to come up with the 300 plus patient and long-term fusion data. But I'm just going to talk to you about that study. And we paired them. We made sure that, if one group is not different than the others. And that's what it says, that, the BMI were comparable. Everything was more or less statistically comparable. So we did our due diligence on that. Then I'm going to come back to that. But it's important to see it here as well, because this shows me every 10 cases I average, and here is only for the time of the surgery, but we do it the same with the blood loss and so on. And it shows me that I'm getting more efficient. And once I hit 40, my efficiency is where I need to be. Now, I had lots of minimal invasive technique, and I needed 40 cases to get really efficient, comfortable with this. Now, I'm calling those 40 cases the 40 case of hell, because you don't have the whole department you're attending and people supporting you for that. Every complication is new to you, and you have to there's no backup. And that is what we are going to change. I want to be a backup. I want to put that 40 cases in the protection situation and to reduce it from 40 to 10. And that's where Inspired Spine comes. We will talk about that later. Now, let's look at the results. And again, let's go back. All the results you see here, they include my 40, there are 60 patients here, right? 40 of them are my learning curve cases. So our 300 cases results are much better than this. And if you exclude my 40 initial learning curve cases, the results are even better than that. So let's go back, look at the time of the surgery. Again, on the TLIF, I had no learning curve. My learning curve was 10 years ago, 15 years ago. And still, my time of surgery is half of the open surgery, my own. I'm not comparing, it is not the surgeon, because it's a one surgeon, single comparative study. My blood loss is 1/10 of open surgery. Days in the hospital, in this study 1.6, in the follow-up study 2.4, if you take the learning curve, even much less. For the first time, this has become a day surgery, truly a day surgery, where patient literally walks out of the surgery center in a good status. And cost comparison. this is cheaper. So we have put, right now, we put all the elements of something that should be standard of care. Only thing what's missing is the fusion and long term, which is coming with our follow-up study, which is being right now, as we speak, is being written. Now, complication. No surgery is free of complication. I mean, and if you go to a surgeon, and that surgeon guarantees you anything or tells you, there's no complication to that, just walk away, because that surgeon is lying. No, but we are comparing it to the standard of care, and the complication rate is lower. And now, something that I was very concerned about is you have to push a nerve when you get to the cabin triangle. Sometimes you have to push the nerve to the side. And I tell that everybody that when I push that nerve to the side, there's a 15% risk of. So I consent them for 15%. We looked at that very specifically. The realistic risk is actually 8%, and it's mostly almost 85 to 90% of the time in the L5S1, which we talk about why later on. I still consent them for 15%. Then if I'm better, nobody can fault me at that. But then what we did though, we went back on my TLIF patient and we compared the same nerve root irritation. It was 12%, meaning that, but the problem with the OLIF is the patient is doing so well that next day after the surgery, that numbness on the top of the left foot, the L5 radiculopathy, or numbness or tingling, or sometimes even sharp pain, rarely though, that shows up much faster. Whereas in a TLIF, they are so miserable one day after the surgery, a little numbness on top of the left foot, they are not even paying attention to that. But if you look carefully, even that complication rate is less than standard of care TLIF. Now, let's go now talk about the os history. So, for people who know that this is either SF36 or os history is where how you evaluate what is your results, and we did that for both TLIF and OLIF, and in every category it beats the standard of care. Every single category. Now, only category they are equal and they are exactly equal is lifting. Now, who can guess why are they equal in the lifting? Any take? No? Because we put them on the same restriction. We don't let them. We ask them not to lift more than this, and that same protocol to the same to all things. So that's the only reason they are equal. Every other category, we are better off than what we call today standard of care. And this is again includes my initial learning curve, initial result, and so on. Our follow-up results are much better than that. Now, I want you to see that, and this is just a multiple level surgery. In the fluoro, I'm just taking the picture and I put them like a video together. And here where you enter, and you see at the same time I'm putting Jamshidi to take my bone marrow. I'm putting you see I'm going there, and pay attention how when the cage or thing going, the distance between the pedicle increases and the foramen opens up. And here, obviously, now the screws are going in. So obviously this is a 3-level surgery. And we are done. No,
Well, you are fast.
no, well, this is, yeah, sure. This is a 1 hour, 20-minute surgery. 3-level fusion, 3 cages, 8 screws. When I was doing it open, this for me would be a 5-hour surgery. Realistically, 5-6 hour surgery, you're pretty good. If you do, I consider myself a fast surgeon, efficient surgeon. But in my hand, if I do a 3-level interbody fusion, it's a realistically 4 or 5 hour surgery. And here I can do that with 1 hour and 20 minutes. Now let's go back and look at this picture. This is the different patient and it's the AP view. And I want to talk about this a little. This is sacrum up. I had forgot to turn it. And I'm doing 5S1. You see how obliquely I'm coming. And this was one of my first 5S1. And you see the cage is very eccentric. We talked about that. That's why I'm showing it to you actually. And then the rest of it, just I put the K-wires and so on and so forth. And the cage is eccentric because I'm trying to go through the Cambin triangle, and I just get a very steep angle, and that let me go in certain direction. By the way, this patient is really great actually. Bone doesn't care how it grows together. If it's a facet in the back, in the front, edge, once it makes the connection, it grows and feels whatever it needs to feel. That's the biology of the bone. Okay, so this patient did great, but if you just look at that, you're not exactly happy with that. We're going to talk later on, there are ways to overcome this problem. So L5S1 is not, I wouldn't say, is something you should start doing all of it. But once you get good at it, and then you apply certain modification, that you can overcome this and make it efficient. So let's go back to the presentation. So faster surgery, minimal blood loss, and all the things that has the characteristic to make this a standard of care. Now, we are not going to talk about that. I think you got the picture of that. Now, our current data, these are our current data as of a few weeks ago, okay? So we are, and me, since this has come out, I have done probably many more. Probably I have done like 20 to 30 more cases. I did just 4 last week. I did, probably 4 or 5 the week before that, and so on and so forth. So we are adding to that pretty. And what I want you to see though, we have enough patients that we are going to do follow-up studies on the listhesis group, on stenosis and deformity. And I'm not talking about the little listhesis. I'm talking about significant listhesis, something that at least 5 millimeter and up. And obviously these numbers, they don't add up to, because some of the patients have the same problem, a different problem. Like some deformity patients have listhesis and stenosis, so that's how it comes to be. But now we are going to run up on each group, each subcategory group, and find out, analyze it. How is it working for those patients? And this is our homework. If we are serious about that, we have to do this kind of work to show the community that this is really working, and for whom it's working and how it's working. Now, coming back to about the learning curve, okay? As surgeon, we are used to see the anatomy, and based on the anatomy, do our action, and it's a real time. Now, OLIF is in a way like looking through a periscope, and every 10 seconds you get a picture, and you imagine you're driving your car. So the current learning curve is realistic, but I think it's something that you can manage. Anything you do is, as a surgeon, anything you do is magic to other people. And this is not that far away. You just need to learn a few more things. And this is actually you there. This is our little cadaver course. We are going to produce a new one of that today, hopefully, which has a time signal. I'm not going to show it to you, but from the start to the time the cage is in, that says 5 minutes and 28 seconds. This is a procedure that, when I started doing that, it would take us only 1.5, 2 hours just to get there, to start doing what I'm doing here. All of that falls away, and that's what saves you time. Okay, now I think I'm pretty much done with this. And here's the learning curve again back. I think that's the important part. And I think our job is now to provide that learning curve in a protected environment to make this standard of care. If you don't do that, if we as surgeons, if you don't do that, I think we are not doing the right thing for our patient. We have to make sure we see the results. I see the results. I see the thing. I have to do my job to make it standard of care for all patients. And you will see that, what I have noticed, that patients are becoming more savvy. And I know you have been doing this for a long time, and I'm not sure how long have you been in practice, or
4 years.
4 years, yeah. People are savvy these days. They look you up. They're minimal invasive. They want that. They understand it. Patients understand more than what we give them credit for. And once you produce this kind of results, you will see you will be ahead of your peers. By far. Now, these are, I have some cards there, but we will forward you all the information. So there's a blog there. Then on the blog, I have people that have scoliosis, have listhesis, and then we talk about the modification of all of those things, how to get there and how to do that. So, any questions? No? Okay.
I have a question.
Yes, please.
Just being layman, what if I were to go to a surgeon and tell him about this and
Mhm.
basically give the value propositions that you just explained to us? What would be the pushback, and what would a surgeon likely say? Yes, but this needs to be done the traditional way because.
Now, if you today would go to a professional conference like AANS, NAS, CNS, and tell a surgeon that you heard a surgeon came and told you he does a surgery like that, not half an hour, in 40 minutes, 1 hour, he would just not believe you. They would think that's just not possible. That's just physically not possible. Because it's a different concept of thinking. Do you guys know Kobayashi, the fast eater guy? Who knows the story of Kobayashi?
I know.
Okay, okay, here. So, what he did, he took a problem and looked at it at a different angle. And then he wasn't, 10%, in every competition it goes 5% better, 3% better, 7% better. He just changed the concept completely. He looked at it as a different angle, that once everybody else looked at it at that angle, the whole, not that I'm telling you it's a great competition, you're putting hot dogs in you, but once you change the concept, that everybody could do that. They were just looking at it from the wrong direction. They couldn't even imagine that something like that is possible. So the first pushback is, no, you be the patient, I'm the surgeon who doesn't know that. Yeah, right. Half an hour, this kind of surgery, he's a charlatan. He's lying to you. People who know more about this, they know that it's a financial situation, and it is, you have to take the time, you have to pay your dues, you have to learn it, and they know that that it is some work involved in that. If they are honest, they take it as a opportunity. But most of the people say, but we don't have long-term results. If they are honest, they will tell you we don't have long-term results, and they are true about that. We don't. But we have short-term result now, as I showed you, and we are working on long-term result. And as somebody who has been involved in that, I send out my, and that's part of what we have to do. We have to be honest about it. Okay. Now, meaning that if I would not be here if the results were bad. I would have abandoned this because I feel that obligation to my patient. Now, they don't know that because people like me, we haven't done our job. That's what's to it, And if we do our job, and once this become peer published, one it's reevaluated, other center can reproduce that, and these things are slow medicine, meaning that what you see is the raptor of fighters. This is the cutting edge of the things. This is thing that people just wow, sort of. This is what has the wow effect. There are not many people are able to do that, but if you get really good at this, you will be in the forefront of it. And that's why I have this, we are going to set up now this Inspired Spine. What is it? It is where we coach people and teach them, as well as patient. We put patient there, and we have this called the Patient Advocacy, Patient Ambassadors program that, these people, and some of those patients I put in my Patient Ambassador program, they have nerve irritation. Some of them, they don't have a perfect results. But this is what we need to do. We need to be honest about it. And this is, I think that's why I'm happy about this country, because this country reward honest people. If you just tell patients, these are the results, this is the percentage, and this, when they expect that, you say, doctor, you told me that. They appreciate that. And this is a, system that rewards hard and good work. Now, we talked about that, for example, nerve root irritation. 15%, I consent them for 15%. And, you know, after my long studies out there, I will adjust it. I'm still, but if I look at that, I see the other procedure has even more. It's actually 8% with the minimal invasive, 12% with the TLIF and so on. And this is a data-driven society. And I think, coming back to your question, his pushback first would be disbelief. The second pushback is, you know, thinking about, oh my God, you know, I'm staying behind the curve, and maybe trying to, if he's not a good surgeon, but if he's a good surgeon, he will tell you, but I don't know the long-term results of that, and in that case, he would be true. But those results are available now.